When a lethal dose of a toxicant saturates the circulatory system, the result is a rapid, catastrophic cardiovascular collapse. We are looking at a system driven into a mechanical stall by a specific molecular blockade. In a standard cardiac arrest, advanced cardiovascular life support protocols prioritize interventions like epinephrine and basic cardiopulmonary resuscitation. But in a toxicological arrest, these macro-level interventions cannot clear the microscopic clusters blocking the receptors. The machinery is jammed at the cellular level. Consider a severe calcium channel blocker overdose. Applying external electrical pacing fails to capture the myocardium. You cannot force an electrical signal through a heart when the literal calcium channels required for muscle contraction are chemically sealed shut. A similar paradox occurs in cyanide poisoning. A clinician can provide high-flow oxygen, but the patient remains deeply hypoxic. The mitochondrial transport chain is chemically halted, meaning the cells are starved of energy while bathed in oxygen they cannot use. Recognizing this failure point, the 2023 American Heart Association guidelines mandate an immediate deviation from standard ACLS. Clinicians must deploy targeted molecular therapies early, relying on clinical toxidromes, the physical signs of specific poisonings, rather than waiting for confirmatory lab results. Treating these arrests requires a shift in first principles. Rather than attempting to memorize a disparate list of over 30 pharmacological antidotes, the clinician must identify the exact physiological location where the poison can be intercepted. That interception happens across 4 distinct pillars. The first is source control and decontamination. At the macroscopic level of the GI tract, we isolate the drug so it can be trapped and excreted before it ever breaches the intestinal wall. If the toxin has already absorbed, we move to the second pillar, receptor antagonism. Here at the synaptic cleft, we deploy competitive molecules to physically outcompete the poison, shielding and organ receptors from further binding. The third pillar is serum neutralization. Within the serum itself, bulky antibody structures and chelators are introduced to hunt down and clamp onto free-floating toxins, rendering them inert. Finally, the fourth pillar addresses the intracellular space, cellular rescue and metabolic bypass. We introduce substrates that bypass blocked mitochondrial machinery, forcing the cellular engine to restart. Correctly identifying the toxin's specific physiological failure point empowers the clinician to deduce the exact category of antidotal intervention required to save the patient. The most effective way to manage a poisoning is to prevent the toxicant from reaching the systemic circulation entirely. Source control is the immediate clinical priority. Historically, clinicians attempted to empty the stomach using emetics like ipecac syrup. This practice is now strictly contraindicated. Inducing vomiting in a patient with a compromised airway dramatically increases the risk of lethal aspiration. The modern standard for source control is single-dose activated charcoal. It acts as a highly porous adsorbent sponge, trapping toxins in the gut lumen. However, its efficacy is generally limited to a strict 1-hour window post-ingestion. This document outlines the explicit contraindications for charcoal use. The PHAILS mnemonic dictates that charcoal is clinically useless against pesticides, hydrocarbons, acids, iron, lithium, and solvents. In some of these cases, administration actually worsens the patient's condition. Conversely, this graphic lists the indications where charcoal is highly effective. The PASST mnemonic confirms strong absorption for antimalarials, barbiturates, carbamazepine, dapsone, and dilantin. Certain drugs undergo enterohepatic recirculation, meaning they are absorbed, processed by the liver, secreted back into the intestines via bile, and reabsorbed. Breaking this continuous loop requires escalating the treatment to multi-dose activated charcoal to trap the drug upon its return to the gut. For heavy metals or sustained-release drug concretions that bypass charcoal entirely, clinicians use whole bowel irrigation. By continuously pumping polyethylene glycol into the stomach, the GI tract is mechanically flushed clear. Source control is the ideal preventative measure, but once a lethal dose breaches the intestinal wall and enters the blood, decontamination is useless. The resuscitation must escalate to the synaptic level. We shift focus to the synaptic cleft. In a critical overdose, the body's endogenous neurotransmitters are completely overwhelmed by an influx of toxic agonists, driving the end organs into failure. We intervene through competitive antagonism. We administer specific antidotes designed to physically outcompete the toxins. They pry the toxic molecules off the receptors and lock into place, shielding the site. The most common clinical application of this is opioid reversal. Naloxone acts as a competitive antagonist at the mu opioid receptor, rapidly restoring a patient's respiratory drive. A similar mechanism exists for benzodiazepine overdoses, where the antidote flumazenil acts as a competitive antagonist at the GABA-A receptor to reverse severe central nervous system depression. This can precipitate life-threatening refractory withdrawal and seizures. In organophosphate poisoning, the mechanism is an overload of acetylcholine at the muscarinic receptors. This induces a lethal triad known as the killer bees: bronchorrhea, bronchospasm, and bradycardia. The patient essentially drowns in their own pulmonary secretions. Reversing this requires aggressive competitive muscarinic inhibition using atropine. The titration strategy is relentless. Clinicians must double the antagonist dose every 5 minutes until the respiratory secretions completely dry up. Receptor antagonism is highly effective for reversible bindings at the synapse, but it offers absolutely no protection against toxins that inflict their damage freely circulating within the bloodstream. For those circulating threats, the narrative moves directly into the bloodstream. We require therapies that can directly bind and neutralize toxins in the serum before they ever reach their target organs. In severe digoxin poisoning, free-floating cardiac glycosides cause life-threatening dysrhythmias. By administering targeted digoxin-specific immune Fab fragments, we deploy massive antibody structures that bind the free digoxin, pulling it away from the heart tissue. We use a similar logic for venomous bites. Polyvalent immune Fab antivenoms are administered to neutralize the systemic cytotoxic and hemotoxic proteins delivered by crotolene snakes, like rattlesnakes and copperheads. This chart details the clinical algorithm for titrating that antivenom. It outlines the criteria for administering the initial 4 to 6 vials to arrest swelling and correct coagulopathy, before stepping down to a strict maintenance infusion schedule to prevent recurrent tissue injury. We see the same therapeutic logic applied to scorpion envenomations. Specialized FAB'2 equine antivenoms are utilized to neutralize the venom and halt the severe autonomic instability caused by the neurotoxins. For heavy metals, we utilize chelation therapy. We inject specific molecules that act as chemical claws, hunting down arsenic, mercury, iron, lead, and thallium in the serum, binding them into tight, non-toxic complexes. Serum neutralization successfully converts active venoms and heavy metals into inert, renally excreted waste. But if the toxin has already bypassed the serum and destroyed the intracellular machinery, catching the remainder in the blood is not enough. We now penetrate the cell membrane to address the most critical failure point in toxicology: the destruction or complete blockade of intracellular enzymatic pathways. In severe acetaminophen toxicity, the liver's endogenous pool of glutathione is rapidly depleted. Without it, a highly reactive metabolite known as NAPQI accumulates, tearing through the hepatocytes and inducing massive hepatic necrosis. The administration of the antidote, N-acetylcysteine, directly replenishes this glutathione pool, providing the exact molecular substrate needed for neutralizing the toxic NAPQI metabolite and saving the liver. In the heart, beta blocker and calcium channel blocker toxicity induce profound cardiogenic shock by starving the myocardium of its vital energy substrates. The surface receptors are entirely blocked. To counter this, clinicians utilize high-dose insulin therapy. The insulin acts as a metabolic battering ram. It bypasses the blocked surface receptors entirely, forcing glucose directly into the failing myocytes to restore contractility. This is frequently paired with adjunctive calcium and glucagon, providing the necessary inotropic and chronotropic support to keep the poisoned heart pumping while the insulin takes effect. For intracellular blockades affecting respiration, the chemical fixes are highly specific. Cyanide toxicity is treated with hydroxycobalamin to form harmless vitamin B12. Methemoglobinemia is treated with methylene blue, which reduces oxidized iron back to its functional state, restoring the cell's ability to utilize oxygen. But when molecular bypass fails entirely, the AHA's ultimate cellular rescue recommendation is mechanical bypass. Implementing venous arterial extracorporeal membrane oxygenation provides vital circulatory support. It keeps the patient viable long enough for the kidneys and liver to clear the toxin. Cellular rescue and metabolic bypass are the ultimate biological safety nets. They keep the internal engines running, even when the surface controls are entirely compromised. Pulling back, we return to the macro view of the crashing patient in the resuscitation bay. Stabilizing a toxicological arrest means operating across all 4 physiological planes simultaneously: securing the gut, shielding the synapse, sweeping the serum, and restarting the cell. This is the philosophy of the 2023 American Heart Association guidelines. Standard resuscitation is not enough. In these critical moments, a clinician cannot wait for definitive laboratory panels to confirm a diagnosis. Survival depends on recognizing the clinical toxidrome in front of you and immediately deploying the correct empiric strategy. Stop the absorption in the gut, block the receptor at the synapse, chelate the serum in the blood, or bypass the failing heart entirely. Standard ACLS protocols will only keep a poisoned patient viable. It is the precise mastery and application of targeted molecular antidotes that actually cures the arrest.